My name is Erastus Thuo. I will be presenting Morel-Lavallee lesions, a rare long-term complication of high-impact trauma. Morel-Lavallee lesions, or MLL, occur when hemolymph accumulates in the potential space between the muscle fascia and subcutaneous tissue following trauma. Shearing forces at the site of injury cause disruption of vascular and lymphatic vessels, which traverse the fascial subcutaneous tissue interface with subsequent leakage of blood and lymphatic fluid. The prevalence of these lesions is 8.3% in acetabular fractures, yet the incidence is debated given their diagnosis is often delayed. MLL commonly occur in the lateral hip, buttock, and knees. A long-term complication of MLL are infections that can progress to cellulitis, abscess, osteomyelitis, and necrosis of surrounding tissues. Our patient is a 22-year-old female with past medical history of anxiety, depression, insomnia, chronic pain, traumatic brain injury, post-traumatic stress disorder, and recurrent MLL of the right thigh from a motor vehicle accident 3 years prior, and she presents with right leg pain and swelling. On admission, her hemoglobin and hematocrit were 9.1 and 27.9 respectively. Her serum chloride was 111. The rest of the CBC, CMP, and physical exam were within the normal range. She underwent 4 sections of irrigation and debridement, or I&D, during her stay. She underwent I&D with wound vac placement on the day of presentation. 3 days later, she underwent another I&D with wound vac exchange. 6 days after admission, she underwent a repeat I&D with partial wound closure. She underwent a final I&D 10 days after admission. Cultures from the first round of debridement grew Staph aureus, while cultures from the second round of debridement grew Staph epidermis, and the last rounds of debridement had no growth on culture. She received cefazolin throughout her inpatient stay and was transitioned to cefadroxil after her last I&D, with instructions to take them for 14 days. Her hospitalization was complicated by 4 episodes of low hemoglobin, requiring packed red blood cell transfusion. In total, she received 6 units of packed red blood cells during her stay. On the 7th day of hospitalization, she had an episode of symptomatic hypotension treated with 1 liter of lactated ringers. On the 8th day of hospitalization, her AST, ALT, and ALK force increased to 414, 207, and 311 respectively. The acute increase in liver function tests was likely due to shock liver. Hepatotoxic drugs were stopped and the liver function test normalized throughout her stay. There are 6 classifications of MLL, depending on the chronicity and MRI features. Our patient had type 3 MLL given the chronic nature of the lesion and the features seen on MRI. The long-term complication of this lesion is increased pain and swelling around the site, as well as infections. There are 3 forms of management of MLL: physiotherapy, medical, and surgical management. Surgical intervention is reserved when conservative management fails. Diagnosis of MLL is typically delayed because most patients have multiple and severe traumatic symptoms after their inciting accident. Therefore, MRI findings are important initial indicators of their manifestations. At the top is a table that shows us how to classify the 6 different types of Morel-Lavallee lesions. In the bottom are the artistic renditions of the 6 types of Morel-Lavallee lesions. Thank you for listening.